Welcome to our second and last video on liver cysts and malignancies. Let's begin. In this lecture, we will discuss Hydatid liver cysts and hepatocellular carcinoma. For each condition in this lecture, we will talk about the definition, risk factors, clinical presentation, diagnosis, and management. Let's start with Hydatid liver cysts. Hydatid liver cysts occur secondary to infection with the parasite Echinococcus granulosus. The major risk factor for Echinococcus granulosus infection is ingestion of food contaminated with dog feces. Hepatic manifestations of Hydatid cysts include hepatomegaly, nausea, vomiting, and right upper quadrant pain. As for the extrahepatic manifestations, rupture of a Hydatid cyst can cause anaphylaxis. In some cases, cysts may form in the lungs and brain. Let's talk about the diagnosis now. Since Hydatid liver cysts are caused by parasitic infection, a complete blood count will typically show eosinophilia. This is because eosinophils fight off parasitic infections. Serology may be positive for anti-Echinococcus IgG or IgM antibodies, depending on whether it's a chronic or acute infection. Ultrasonography will reveal hepatic cysts with eggshell calcifications and internal septations. This is an ultrasound image of a patient with Hydatid liver cysts. Please note these cysts with peripheral eggshell calcification in the liver. In this CT image of a patient with Hydatid liver cysts, one can appreciate multiple cysts here on the left side of the liver, indicated by the white arrow. Notice the septations in the mass, indicating that this mass consists of many smaller cysts. Small cysts, less than 5 centimeters in diameter, are treated with albendazole. Large cysts are treated with imaging-guided percutaneous drainage in combination with albendazole. Complicated cysts, such as those consisting of many smaller cysts, or a cyst with rupture or infection, may require surgical removal in addition to albendazole. How can a Hydatid liver cyst and a hepatic adenoma be distinguished on imaging? On ultrasound, the Hydatid liver cyst presents as a smooth cyst with peripheral calcifications. There may also be septations present. In contrast, a hepatic adenoma presents as a solid mass on the ultrasound. Let's finish off this lecture by discussing hepatocellular carcinoma. Hepatocellular carcinoma is the primary malignant tumor of the liver. Cirrhosis due to any cause can predispose the patient to hepatocellular carcinoma. These causes may include non-alcoholic fatty liver disease, Wilson disease, hemochromatosis, hepatitis C, and a variety of other conditions. Alcohol and chronic hepatitis B infection are independent risk factors for hepatocellular carcinoma. Finally, aflatoxins produced by Aspergillus can cause hepatocellular carcinoma. Hepatocellular carcinoma may be asymptomatic. However, it commonly causes nonspecific symptoms like weight loss and mild fever. Most patients with hepatocellular carcinoma present with signs of decompensated cirrhosis such as jaundice, ascites, coagulopathy, and hepatosplenomegaly. Additionally, the patient may complain of metastasis-related symptoms such as bone pain. Hepatocellular carcinoma may be accompanied by an inappropriate absolute polycythemia due to paraneoplastic erythropoietin production. Polycythemia, in turn, can increase the risk of thrombotic events. Hepatocellular carcinoma can also cause Budd-Chiari syndrome. Budd-Chiari syndrome is hepatic vein thrombosis. In the case of hepatocellular carcinoma, Budd-Chiari syndrome arises due to blood hyperviscosity from polycythemia, or direct spread of cancer into the hepatic vein. Budd-Chiari syndrome is characterized by an acute exacerbation of abdominal pain, ascites, and hepatosplenomegaly. Let's move on to the diagnosis. First, high-risk patients, particularly those with cirrhosis, should be screened for hepatocellular carcinoma with serum alpha-fetoprotein and abdominal ultrasound every 6 months. Serum AFP is useful to evaluate for hepatocellular carcinoma only when it's elevated. This is because normal alpha-fetoprotein levels do not exclude the hepatocellular carcinoma. Among the imaging modalities, ultrasonography is the best initial step. Right upper quadrant ultrasound in a patient with hepatocellular carcinoma typically shows a mass with irregular borders. Triple phase contrast CT usually shows a hypodense irregular mass. Definitive diagnosis is made by ultrasound-guided liver biopsy. This is the triple phase CT scan image of the hepatocellular carcinoma. Notice this hypodense mass with irregular borders on the left side of the liver. This finding is very characteristic of hepatocellular carcinoma. Management of hepatocellular carcinoma is complex, multidisciplinary, and largely outside the scope of Step 2 CK exam. Generally, management options include surgical resection, ablative therapy, chemotherapy, and liver transplantation. In order to prevent the development of hepatocellular carcinoma from chronic hepatitis B infection, we should administer hepatitis B vaccination to the patient. Additionally, alcohol avoidance can help prevent the development of hepatocellular carcinoma since alcohol is both an independent risk factor for the disease and can lead to cirrhosis, which is a risk factor as well. A 62-year-old man with a 30-year history of alcoholic cirrhosis comes to the physician with an unintentional 15 kilograms of weight loss over 4 months. His jaundice and right upper quadrant discomfort have worsened since then. His urine color is darker than before. Physical exam shows a positive abdominal fluid wave test and muscle atrophy of the extremities. What is the best initial imaging modality in the diagnosis of this patient's current condition? This patient with a 30-year history of alcoholic cirrhosis comes to the physician with an unintentional 15 kilograms of weight loss over 4 months. His jaundice and right upper quadrant discomfort have worsened since then, and his urine color is darker than before. These changes suggest an obstructive jaundice due to the hepatic mass. Clinical deterioration of the patient with long-standing cirrhosis raises suspicion for hepatocellular carcinoma. The best initial imaging modality in the diagnosis of the suspected hepatocellular carcinoma is a right upper quadrant ultrasound. Here is the table summarizing all the conditions we talked about in this lecture and the previous one. Pause the video and take a moment to consider this table. A 36-year-old woman presents to the physician with dull right upper quadrant pain for the past 6 months. She is a farmer. She stopped taking oral contraceptive pills a year ago. She does not drink alcohol or smoke cigarettes. Viral hepatitis panel is negative. Her vital signs include a temperature of 36 degrees Celsius, blood pressure of 125/85, heart rate of 70, and respiratory rate of 14. The right upper quadrant ultrasound shows a 3 centimeter hepatic mass with a hypoechoic center, internal septations, and a hyperechoic calcified rim. Which of the following is the most likely diagnosis in this patient? A. Hepatic adenoma. B. Hydatid liver cyst. C. Cavernous hemangioma. Or D. Focal nodular hyperplasia. This woman presents with right upper quadrant pain for 6 months. Right upper quadrant ultrasound shows a 3 centimeter hepatic mass with a hypoechoic center, internal septations, and a hyperechoic calcified rim. This description is consistent with a hepatic cyst accompanied by a peripheral eggshell calcification. Considering that she is a farmer with possible exposure to dog and sheep, her mass is most likely a hydatid liver cyst caused by Echinococcus granulosus infection. So the correct answer is option B. Here's a slide reminding us of the diagnosis of the hydatid liver cyst. Let's discuss now why other options are incorrect. Option A, hepatic adenoma, is incorrect because it presents as a well-demarcated hyperechoic lesion on hepatic ultrasound. Option C, cavernous hemangioma, is incorrect because the ultrasound typically shows a hyperechoic homogeneous mass in patients with cavernous hemangioma. Finally, option D, focal nodular hyperplasia, is incorrect because it presents as a mass with central arteries and a spoke wheel appearance. And that concludes our lecture on the liver cysts and malignancies.